Okay, so I think we're ready to get started. Great to have you all here and welcome to our monthly webinar. My name is Natalie De Navarro and I'm Customer Success Manager at Collective Minds. And here today I have consultant radiologist Dr. Imran Lasker with me, and he will be presenting plain film and CT cases. But before we begin, I have some information that I think will be useful for you to know and have in mind during the webinar. So first of all, if you want to be able to go through the cases that Dr. Imran Lasker will be presenting, you can do so through our collection. So I'm going to post a link here and a password. And even if you don't have a Collective Minds account yet, you will actually be able to go through the cases together with Dr. Lasker. So let's see. So by clicking on the link and entering the password, you should be able to enter the case collection that we will be going through today. If you want to be able to access the cases from tomorrow and onwards, you will need to have an account on Collective Minds. And when logging in, you'll be able to see the cases there in our global community. Today, we will also have a couple of polls, and we hope we'll get a lot of answers from you all. If you have any questions for Dr. Lasker, please use the Q&A. We'll be looking through those. And also, if you have questions for me or in need of any support, feel free to either just chat directly to me via the Zoom chat or send an email to support@cmrad.com and I will help you. When it comes to, I see there's a question around the certificate. So for those who are here today, and if you then also fill out a short evaluation form, which I will share the link to at the end of the session, you will then receive a CPD certificate from us by tomorrow. So by being here today and then filling out the evaluation, we will then send you a CPD certificate via email. So please let us know if you haven't received it by end of day tomorrow. And I'll send the support email here in the chat as well, so you can easily reach us if anything. And let me see. Here we go. So with that said, I think we're ready to get started. So I'm going to hand over to you, Dr. Imran Lasker.
So, hi everyone. Thank you so much for turning up to this talk today. I'm just going to share my screen. It's a bit sunny today, and very hot. So I've got the AC on. So apologies in advance if you can hear the AC in the background just whirring away. I'll keep track of everything. So I'll keep track of the Q&A and also keep track of the webinar chat. So feel free to ask questions during it. Like I always say, there's more kind of for learning, a bit of fun as well, because radiology is kind of cool. And yeah, it'll be good. So, because often I end up learning from you guys as well. So I really do appreciate any interaction that we have. So hopefully by now you've got access to the Collective Minds platform. For those of you that don't know, I think you'll be able to access this for the day. We're using that password and the link that we've given you, which is really great, actually. Sounds like it could be something quite useful for those times when you're running conferences and you need to be able to do quizzes and that kind of thing. And if I remember correctly, they recently did that at UKIO. Anyway. So I've been working with Collective Minds for a really long time. I use it for all of my own teaching, especially through my own platform called Radiology Seminar. So if you are interested in getting more teaching from us, then please go and check it out. What we're going to do now is go through these cases. I have handpicked about 9 cases going through varying levels of ability. Because I know, some people are very good at imaging and they know quite a lot already, but there'll be people that here that are just getting into imaging or just want to kind of learn a few things, which is also fine. So let's go through case number 1. So when you open case number 1, do press that little cloud button and that will make things slightly easier. And what we'll do, we'll kind of concentrate on this particular scan first, and we'll scroll through. And what we can see here is that this is a non-contrast study, right? So non-contrast study. And I always try and make sure I do at least one scroll through all the way through to the end, just to make sure I haven't missed anything. And especially looking at the last slice, as a good friend of mine said, the last slice could slice your career, because there has been occasions where people have missed C-spine fractures, all sorts of abnormalities, tumors, lesions, all that kind of thing on literally the last slice. So it's very, very important. You scroll all the way to the bottom until you can't scroll anymore. Same as all the way to the top. Keep scrolling until you can't scroll anymore at all. So this one, So far, we haven't seen anything grossly abnormal, and I actually like to try and rotate the images and make sure that it's kind of exactly the way that I'm used to seeing the images all the way through my life. I know your head can have a little bit of multiplanar imaging on some level, but I like to try and keep things simple for a simple mind like mine. So then, as you kind of scroll through, everything looks kind of symmetrical. Coming further down, it might be a bit difficult to see anything. So no one's seen anything just yet, but maybe the next scan will kind of give us a clue as to what's happening. Let's come back up. And then one of the things I think are a bit underrated is using the stroke windows. So what you can do, I think you have stroke windows here. So I'm going to try and do the stroke windows. I'm doing this just by pressing the numbers here, but actually that might be a little bit too much. So what I'm going to do is go to windowing and just do this a bit, just to try and see whether you can see the gray white matter differentiation. So gray white matter differentiation is where you can see this gray matter sitting around here, and there's the white matter. You can kind of almost see a line. For those that can't see that, I'm going to zoom in a bit to try and convince you. Can you see there's like a line going like this, a line going like this, going like a line going like this, and then there is a bit of this kind of blackish stuff, and that's going to be your white matter. That's going to be your gray matter. And as you kind of go around here, it feels like you can't see it as well as you used to. And that pretty much is it, isn't it? Like you can kind of scroll now up and down, and around here it just looks very, very odd, doesn't it? It looks like there's a loss of great white matter differentiation. Compare this side, if you draw a square and draw a square there, that looks very, very different. This entire area looks very, very kind of black, goes all the way along like this, and the posterior aspect of the parietal lobe continues to happen all the way further down. And it's not till you get to around here, you start to feel like you get a bit of grey white matter differentiation back again. So if we go back to the original window, it can be a little bit difficult to see on the normal brain windows, but now you start to see, yeah, there is a bit of a difference. Now, what can happen after a bit of ischemia, this is exactly what it is that sometimes you just get a bit of brain swelling, and sometimes you just have a lack of CSF space on this side compared to this side. But on this one, it's a little bit deceiving because the CSF spaces look completely fine. It's just that lack of great white matter differentiation that's really making us think that there could be a stroke going on here. So I think we did have a question, a poll question that hopefully will come up in just a second. And it's kind of asking you, what would you do next? So obviously, this is one of the scans you could do next, but there's another scan that we'd want to do. And if we did that, what we'd be looking for? On that scan. So let's have a look at this one. So this is the CT angiogram. And what they've essentially done is put in contrast into the vessels and timed it so it's within the intracranial vessels. And we'll also be able to have a look at the carotid arteries and the vertebral arteries and all the rest of it. So let's go all the way down to the aortic arch. So this is the aortic arch. We're coming up, we're coming up, we're coming up. And if we just follow this one over here, this is going to be the common carotid, and then we're going to split. So you can see it kind of splits there, and then it kind of looks a bit abnormal. So maybe we need to look at a different window. And you can see that there is some atherosclerosis and significant sort of thrombosis there, like complete thrombosis, and there's just complete lack of contrast sitting there. And that's asymmetrical, isn't it? So you look at this side compared to this side, you got two vessels. On this side, you got this side, and this vessel just completely is not there. Follow that up, follow that up, follow that up, follow that up. And now we can come up to these sort of intracranial portions, the petrous portions of the carotid artery. And again, there's just no contrast sitting there whatsoever. And coming further up, yeah, now you start to get a bit of reconstitution, more because of the circle of Willis, and the rest of the blood flow has resulted in some blood flow getting there. But definitely at the sort of main internal carotid artery, there's a complete lack of contrast going through. And that seems to be emanating from the region of the bifurcation of the common carotid artery. Quite important to have a look at the rest of the vessel. So for those that don't know, this vessel over here is going to be the vertebral artery. Quite important to look at because sometimes people have significant neck injuries. It doesn't have to be a fracture. Sometimes it's just the acceleration, deceleration injury that can result in obstruction to flow. And then both vertebral arteries join to become the basilar artery that's sitting over here. Coming further down, let's just have a quick look at the other artery. So this vertebral artery looks a bit thin. And that's thin, but it's fine. You can have a thin artery that can just be constitutional or just the way the person is. That's nothing major to worry about. So actually, in this particular scan, what we've seen is that there is a significant thrombosis involving the left internal carotid artery from the bifurcation all the way through to the level of the circle of Willis. And that is pretty much what's causing this person's ischemic or blood clot that has resulted in a lack of blood getting into the getting into the brain. So someone said have a look at the coronals. You said coronals, yeah, you said coronals. Let's have a look. Actually, I quite like doing. How do I get back? Okay, so coronal is going to be quite good. So we can have a look and see. So let's come up, come up, come up, come up, and where are we? I think it's because it's twisted round. It's not the best way to do it, I think. So I'd rather, if I can, I think you do like misc oblique or something, isn't it? And then go to layout one. So once it loads up, we may be able to manipulate it just a little bit more. Oh, hang on. Let's go there and go one by one. Okay, that didn't work. Let's put that there and then go misc oblique. That's better for me anyway. And then we can kind of turn this around. And this is what I find really impressive about this platform is that it's pretty much a fully fledged Dicom viewer that just sitting on the internet. It's just completely crazy to me. Okay, so let's have a look, see where we are. So we are coming up from the aortic arch. What have we got here? We're coming up to here, is it? Carotid. And this is around here is where you've got that significant calcification, don't you? And then you've got a complete lack of contrast going further up. And what you can do is actually increase the MIP as well to try and have a look at the vessels a little bit better. And you can see how this vessel goes all the way up and this vessel just kind of completely stops. And it's quite a pretty picture, isn't it, actually? Okay, right. So what we're going to do now is go across to case 1B, which is actually the follow-up of the previous case. And you can see corresponds to the abnormal area, right? And so what we're looking at here is the diffusion weighted imaging. Ideally, you want to have the ADC map as well, but just take my word for it. It was low on all of these things. And it took me ages trying to understand diffusion weighted imaging and all that kind of thing. And I find that even now it can be a little bit difficult. But the way I try and imagine it is that like the water inside the human body is like a kid. And it's like, like if you've got kids, especially young ones like mine's are 5 and 8, and they're really, really hyperactive. Like I don't know how much they got so much energy, how they got so much energy. And so let's say the water is running around the body, being like a little kid, having a great time, and then suddenly you decide to just hold it in one place. The kids are start gonna get really angry, really aggravated. And that's the way I kind of imagine it to be in diffusion weighted imaging, that you've got water flying around and it's great, it's not making a big fuss. As soon as you kind of hold it in one place, that's when it starts to get really angry and you start to see it look really, really bright. And that can happen in abscesses, it can happen in some tumors, and can happen in ischemic events because the water is now stuck, it's not going anywhere, it gets really angry, and then ends up kind of giving this high signal. And yeah, like you said, very, very quite impressive amount of ischemia compared to the CT scan. Actually, let's have a look. So we saw all that area. Let's look at that area and let's have a look at that area. So now we know that actually it looks like some of the frontal lobe has been involved. So was that the case in the original CT scan? Let's have a look, because I think when it was called, it was mainly called because of the parietal lobe. Let's try and just window that a little bit. You can tell me if you can see it on the frontal. And oh yeah, let's download the images so it's a little bit smoother. I've finally got fiber broadband, guys. Changed my life. Okay, let's see. I'm not convinced you can really 100% say you can see it. I mean, compared to this area, that area doesn't look so bad, does it? So maybe it progressed since that, since the original scan. That could be the possibility. So if you were to do a repeat CT scan, maybe you'd see areas of loss of gray white matter differentiation involving the more anterior aspects. Okay, good. Yeah, exactly. I know someone asked about ADC map. I did not download the ADC map, so you're going to have to just take my word for it that it was low in significant proportions of that brain. Okay, so yeah, and so ADC map is where what you do, you've got your diffusion weighted imaging and you've got your ADC map. And the ADC map, if it's low on ADC and high on diffusion weighted imaging, then you're looking at a stroke. If it's high on both, then you're not looking at a stroke, you're looking at something else, so like T2 shine through or something. Right, so let's have a look at this scan. And this is a different patient, and this was a trauma patient. So I've downloaded the images. Please feel free to download the images as well. And then just scroll through. And don't worry, when you download it, it's not downloading onto your hard drive or anything. It's like temporary, and then it will go. It's not going to take up all your disk space. Okay, so let's scroll through. Let's go through. Let's go through. So this is a non-contrast CT scan. And I don't know about you, but I haven't seen anything grossly abnormal just yet. So this person's they've had trauma, from what I remember. And so what we can see is they've got a significant amount of widespread evolutionary changes. Now, sometimes people get a bit worried that this could be like a chronic subdural, but it's very, very equidistant. And you can also see these kind of vessels going through it. So when you've got vessels going through it, you're less likely to have a subdural hematoma pushing things in. This is more likely to be just really prominent CSF spaces, and you can see the vessels kind of scrolling through all the way there, all the way there. And that's kind of normal for this person. You can see some low density around the ventricular system as well. That's going to be sort of a small vessel disease, and that's very, very normal for older patients. So again, I don't think we've seen anything grossly abnormal here. So we're really struggling, aren't we? So what we'll do, we'll go to the bone windows. And sometimes these things, oh yeah, so remember I said last slice could be the end of your career. So we've got to have a look at the C-spine as well, just to make sure there's no obvious fracture. And that C1 vertebra actually looks okay, doesn't it? So what we'll do now is we will go down to, we'll go to these images and just scroll through again. So let's scroll through and just see if we can find anything. Has anyone seen anything? Okay, let's scroll through, let's scroll through, let's scroll through. Okay, let's have a look at that C-spine. So C-spine looks okay, doesn't it? You can draw quite nicely. Doesn't look like there's any odontoid peg fracture. Yeah, the spinous processes all look okay, don't they? And then what we can do is kind of line this up a bit better, bring this down to this level. Yeah, that C-spine looks okay. What we can do is kind of increase. So one of the tips I've given you guys over time is just to increase the MIP thickness. I would probably go about 30 to 40. And then what I do is window it so that I can see the bones a little bit better. And then like really interrogate the bones a lot better. So it just makes it a little bit more easier to see like a 3D structure. So let's scroll through. So yeah, that looks okay, doesn't it? Everything looks okay. Can't see any obvious facial bone fractures. So you may think to yourself, yeah, okay, well done. Someone's got it. Good. So then, yeah, so you may think to yourself, it's okay. It's all good. But now what we'll do, if we go back to this sort of thin images, can you see that? Exactly. Someone has said it exactly right. So there, yeah, there is a fracture sitting right there, and that can be so easily missed. And actually, once we had this case where they did the CT scan, patient was unconscious, everything was fine, but when they woke up, they couldn't talk. And people are thinking maybe they had a stroke or something, but it turned out they actually had bilateral mandibular, like they dislocated the mandible. When you look back at the CT scan, this was like so far forward. So, and yeah, I mean, this is one of those check areas that you always should have, but you can see now, if you compare that to that side, there's clearly a fracture going through there and it's slightly displaced as well, which would result in this person not being able to probably talk. And then, yeah, people might get worried that they've had a ischemic event, but they haven't. They've just broken their bone, which is not great, but they're broken the bone. Okay, cool. So well done. Yeah, we did pick that up. Okay, so we are going to go to an X-ray, and like I said, we're trying to do some easier stuff, and as hopefully the talk goes on, we'll go through some more slightly more difficult things. Okay. Right, so this looks like an adult patient. Okay, that's good. And one of the things you want to do, so the way I normally do it is I have a look at it, have a good look at the lungs, just a first inspection, have a look at the mediastinum, make sure that's okay. Look at the costophonic angles, make sure that they're very, very sharp. And then I also look at the lung apices, and I always draw a square, right? And I compare the squares to one another. And when I draw that square, was there a second fracture of the mandible? Yeah, okay, that's a good point. I'm going to come back. I'll come back to that one just to be sure. I don't remember there being a second fracture. So you might be saying that because usually you would get a second fracture of the mandible. So I can't remember. I'll have to look. So, okay. So then, yeah, so exactly right. So when you draw that square, if we zoom in, can't open the cases. So someone can't open the cases, unfortunately. Okay, so let's zoom in. Did you try the link and do the password? Yeah, so now what you do, you log in, and I mean, so you have a look and you see that you can see lung markings all the way to the edges, can't you? But this one, lung markings kind of just stop here, just there. So yeah, it looks like they've got a left apical pneumothorax, right? Complete lack of lung markings that's going on this area over here. And it's quite important just to be sure there's no fractures anywhere because, yes, they can be spontaneous, but they can be post-traumatic. And I don't think I can see any fractures anywhere. No, I don't think I can. And let's have a look at the rest of the lungs. Yeah, so it doesn't look like anything else going on. So this is a pneumothorax located within the left apex. So someone is saying about a second mandibular fracture beyond the one that I saw. So let's have a look. We're going to go back to case, whatever that was, case number 2. We'll go to bone windows, bone windows, which is this one. And oh yeah, download the images so it's a bit more smooth. Come down. So yeah, I know that we usually would say that when you get a fracture of the mandible because of the ring-like structure, you should get two fractures, don't you? Like is this going to work? Let's do this. I don't remember there being a second fracture on this one, to be honest with you, but let's have a look. Maybe there is one. So that's the mandible body. They've got really bad teeth, don't they? Unfortunately, fractures there. Any fractures on that side? Not really. Let's go to the side to side. So this is the non-fractured side, coming across, coming across, coming across, coming across. And that tooth looks like it might fall out. Anyway, so coming across, coming across, coming across. Yeah, I can't think I can instantly, unless you think that maybe there's a fracture. Well, no, that is the fracture we were talking about earlier. So yeah, I don't think there is a second fracture on this one, from what I can see. Let me know, but I don't think I've seen one. So I know we've been taught that there usually is a second fracture, but I don't think I saw one on that one. Okay, let's go to this one. Hopefully it's not too bad. Well, not great for the patient, unfortunately. Okay, so this is a chest X-ray of an adult patient. Oh yeah, so what case is this? Yeah, fine. So this is a chest X-ray of an adult patient, and we can see they're adult because the growth plates are nicely done. I mean, nicely fused. Lung apices, we don't have a pneumothorax this time, but there are some abnormalities, right? So let's have a look. So there are some abnormalities, aren't there? Look at that. So there's a nodule sitting there, and sometimes you think, okay, could that be like a nipple? But it seems asymmetrical from one side to the other. And actually, as you kind of look a bit closer, there are multiple of these lesions scattered throughout both hemithoraces, right? And actually, a larger of the lesions are located in the lower lobes. And these look like they're soft tissue density. They don't look like bone because you look at the bone, bone looks like that. It doesn't look like bone. It doesn't look like air because you know air looks like that or like that. But soft tissue looks like this, and this looks like soft tissue. So these look like multiple soft tissue densities located throughout both hemithoraces with a predominance for the lower lobes. So when you see something like that, you have to be worried that there could be an underlying malignancy. And sometimes it can be a good idea just to have a look at the bones. Also, if there is a breast shadow, have a look at the breast shadow and see if you can find anything grossly abnormal. But I don't think we can really glean much more information from this particular X-ray beyond the fact that we're very concerned that the lower lobe distribution of these nodules or lesions is highly concerned for underlying malignancy. Now, the reason why I think I read about this. So the reason why you get so many larger lesions in the lower lobes rather than the upper lobes is because the blood flow kind of stasis or kind of slower blood flow is at the bottom of the lungs. And so what can happen is that you get the larger lesions or metastatic lesions in the lower lobes rather than the upper lobes. And what we have is the subsequent, oh yeah, so there was someone saying something. There is also something else there. So let's open that one. So we are case number 4. What was I saying? So these are there are multiple lesions located in both lower lobes, which would be concerning for underlying malignancy. But then when you actually look at this area over here, can you see how it's kind of a bit more shadowy compared to the other side? So when you look at it, I don't think you can be 100% that there's reticular shadowing. Someone says lymphangitis, I guess is what you're asking. Now, I try on chest X-ray, unless it's blindingly obvious, I don't really go for it. And I think what we can say is that there's definitely some consolidation here. There's definitely some airspace shadowing. Is it net-like thickening of the lines across there? I don't think I can 100% say because I guess these areas look net-like-ish, but not really thickened. So we're not looking at sort of any interlobular septal thickening on here. Now, when we go up to the CT scan, so this is part 4B, we can see this is the CT scan of this particular patient. And as you come from the very, very top, you can see that there are a few kind of more radiolucent areas in the lung apices, very, very common. Maybe, someone like me who lives in London is probably going to end up having lungs like this, where you get a bit of emphysema in the lung apices. But as you kind of scroll through, you can see one lesion sitting there. Come further down, a bit of what ground glass stuff sitting there. Coming further down, another nodule sitting there, another nodule sitting there. And oops, sorry, happy face. Keep scrolling, keep scrolling. You can see multiple nodules all over the place, can't you? Quite a significant number of nodules. And actually, someone said about lymphangitis, here, it does look like a little bit net-like. Can you see all this? It all looks a bit net-like around here. So you can say that there's some interlobular septal thickening located within this region. And further down, you can see there are a few more lesions located in both lower lobes. And also, I think when you look at that airway, so look at this airway. So the airways are here. They look very, very thickened. And as you come down some of these airways, they look kind of plugged all the way through. Now, the other thing, what I'll do is if we go, let's go mist oblique again. I quite like this mist oblique thing they've got. And then you go MIP. This makes it a lot easier to try and see nodules. And the way I say it is that as radiologists, or as you kind of get more and more used to looking at imaging, what you'll find is that your brain gets good at following structures, and normally structures of the human body lead into other structures. So all of these lines should lead into other lines essentially. But occasionally you will see these kind of blobs that plop out of nowhere, like decorations on a Christmas tree, and that's when you've got something abnormal. That's how you look for nodules. Now, the primary, I don't think I remember what the primary was. I think this person ended up having a full CT scan. But before I say that, let's just have a look at the upper body, because occasionally you'll have like a lung tumor. It doesn't have to be melanoma. It could be any malignancy, really, anything that could be bloodborne. And I have on the occasion seen something like a renal malignancy sitting there, splenic malignancy, anything. So you've got to really have a look at the rest of the upper abdominal solid organs to make sure there's nothing else going on there. Can you see these things here are lymph nodes? They kind of turn up and disappear, turn up and disappear, turn up and disappear. Look, a large one there, turn up and disappear. So if something turns up and disappears, that's usually abnormal. And these ones look like they may have some low density within there as well. So if we come to this one, looks like it could be a bit of a low density component to it. To be concerned, there could be sort of necrotic lymph nodes within this person's body as well. So, I mean, if you don't have a pleural effusion to go for and you can't find a primary, then it may be worth going by EBUS, so endobronchial, to try and get one of these samples of a lymph node if possible. But yeah, this is not a good outcome for this patient, unfortunately. Right, so let's go. So we've done that case. So case number 5, we do have a poll. So if we can get that poll out. Yeah, a wide differential for that, honestly. So I'm going to keep that poll over there, and we'll scroll through this. Okay, so this looks like it's a non-contrast CT scan of the pelvis, and what we're going to do is go through, go through, go through, go through, go through, go through. Okay, so we've got bony images here, and I can't see any fractures or anything else. I mean, I guess that it's not a trauma scan. Let's go from the front. Okay, so bones wise, we're doing okay, aren't we? So let's have a look at the soft tissue windows and have a look at the rest of the structures. So let's have a look at the bowel, I guess. So let's see, look at the bowel. Bowel's going this way. See that calcification sitting there? Can you see that? So that can happen because they've had previous infarcted epiploic appendages, and they've got another one there. Sometimes that can happen. And maybe they didn't feel it, maybe they did, and they kind of infarct and become these calcifications. So bowel actually looks okay, doesn't it? So what else is going on in this one? Let's have a look. Oh yeah, okay, cool. What has everyone said? So, okay, good. So what we can see here are multiple stones, I think. How many we've got? One, two, three, four, maybe even five. Okay, if we keep our eyes on this area over here and then go coronal on this. So that's going to be the bladder. Coming backwards is going to be the ureter. And look, that looks like there could be a few there. Let's zoom in. Okay, look, one, wait, what, two, maybe even three. So like it looks like there's a few. So yeah, for those that don't know, I mean there's something called Steinstrasse, like Stone Street, and it can be quite a common thing and I've actually seen similar things with like the gallbladder, no, the CBD where you just get like multiple stones in a row. But this is yeah, multiple stones in a, it looks like at least what, three, four, maybe even five stones sitting within the distal ureter. It can happen after ESW, like shock wave therapy, where you try and break up the stone up here and it kind of falls down, ends up in the ureters, and then you end up having like multiple stones in a row like this. So yeah, this looks like this to me, like a Steinstrasse appearance to the distal ureter. And actually, interestingly, yeah, most people got that, I think. Yeah, good. Interestingly, is there much in the way of ureteric obstruction? Let's go have a look and see. Let's find those stones. It looks very thickened, doesn't it? So it looks like could be there for a while, causing a bit of inflammation. But the aorta doesn't look too bad, does it? You'd expect that to be really, really big as a result of so many stones. I think that's the appendix sitting there, isn't it? That little thin thing there. I'll just quickly show you anyone that might be interested. That tube there, going that way, that way, that way, that way, that way, all the way to the cecal pole, and then that's the ileocecal valve, which is that fatty lip area, I think that I've talked about in previous talks. Okay, yeah. So did I say right? I mean left. If I said that, sometimes that happens. Okay, look, let's go to the next case. Next case is case number 6. Let's have a look. Is it this one? No, let's not do case number 6. Let's go do case number 7 first. I think they're meant to be the other way around. Let's do case number 7 first. Case number 7. Okay, so it looks like a young person. And what we'll do is zoom in and have a look around. So I always say, try and draw a bad line around the growth plate. So if you were to draw a line like this and go in like this, then you say, oh, you know what, this is slipped. But that's not the case. You've got to draw a line and kind of come outwards slightly and then inwards again, right? And try and do that with all the kind of growth plates, outwards and then inwards, outwards and then inwards, right? So this is the scaphoid, is going to be the lunate. This is going to be that's going to be the hamate. That can be the what, the praquetrum, I guess. Um, and you said someone said capitate, is it? So capitate and trapezium sitting there. So they said capitate. So let's zoom in and see what's going on with the capitate. So capitate actually looks okay to me. Doesn't look like it looks for a kind of, I mean, I know doing a terrible line around it, but what we'll do, we'll have a look at the other views just to be sure. But that's the capitate sitting there. That looks okay. Yeah, I think we're okay here. The other good thing to do is to try and draw around the radius and ulna. And radius and ulna, actually, if you draw a line, like I said, a bad line around it. So keep drawing around. Yeah, that looks all good as well, doesn't it? Yeah, so someone's come out with it. Quite a young kid. Maybe they got into a bit of a scuffle at school. And yeah, if you kind of draw a line around every single metacarpal, keep going, keep going, keep going. A very common place, and almost the first place I look for in any hand X-ray is to have a look at this area. And you can see that this is slightly angulated forward. Can't you? Can you see that? And if we zoom in a bit, you might be able to see an actual fracture line there as well. So it feels like there's a linear line going all the way through like that. And that is one view. Can we see it there as well to confirm? Zoom in. It does look like there's a bit of increased sclerosis and a bit of impaction, and it's been slightly angulated forward. And let's see in this view here. Do we get to see it there as well? A little bit more difficult, isn't it? But there's definitely a fracture. Exactly right. So, boxer, bad boxer. Yeah, someone who's, ideally should be punching with the front two knuckles, not that side. The forces are all wrong and they've ended up fracturing themselves. So, yeah, not great. Let's go to case number 6 and then we'll go to case number 7. So case number 6, patient came in with long-standing hand pain, and I thought it was interesting because it kind of, yeah, it wasn't exactly seen initially. So let's have a look at this one. Yeah, wow, you're rapid, man. Okay, good. So that's the radius, that's the ulna, and this is going to be the lunate capitate. You got your proximal row, your distal row, that all look okay. Then I genuinely would say draw on every single bone. Do have special attention to the 4th and 5th metacarpals because often these guys get fractured because someone has punched incorrectly. Haven't seen anything grossly abnormal. Joint spaces, they all look nicely well preserved. They look like they are a pretty young patient, actually. And then you keep drawing around, keep drawing around, keep drawing around. You've got your terminal tufts, phalanges, terminal tufts, phalanges, keep drawing, keep drawing, keep drawing. Generally, this is how I would do things, like just draw, 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 like proximal phalanx there. What someone said, yeah, good. Ulnar mass effect, erosion, ulnar aspect of second. Yeah, so yeah, exactly. So that's completely right. So if you look at this one and we zoom in a bit onto the terminal phalanx of the index finger, you can see that this area over here looks slightly abnormal. Like at first glance, you may just walk past it, but if you compare it to the next one, you got that. But this one looks like it's a bit thinner. It looks like it's been kind of caved in a bit by something. So there's been some sort of scalloping. Now, one of the important things to do is try and see whether you think it looks aggressive versus non-aggressive. Now, that basically tell you whether it's like an underlying, like, so if it's non-aggressive, then you will have quite a well-defined line. And I think you got quite a well-defined line. Don't see much in the way of soft tissue reaction because the soft tissues actually look pretty good. You can't see any cortication around it either. So it doesn't look like we're seeing a aggressive lesion, but it does look like there's some sort of scalloping. So some sort of mass is causing this particular appearance. So at this point, any ideas what could be causing that? And I don't think we've got it anywhere else, have we? Let's have a look. So all the other terminal phalanges look okay. Thin eminence, yeah, I can see why you'd say that, but this is fine. I wouldn't look too much into that. There wasn't any lesions there. Everything else, yeah, everything else looks okay. So, person came in to have ultrasound. So let's have a look at this one. So case 7B. Hopefully this has come across nicely. I've got the right images. So yeah, can you see exactly where we were looking at? There was this spherical lesion located within that area. Yeah, I mean, I think it's pretty much what they call it, or GCT, giant cell tumor, of the tendon sheath. And you can see it's very, very vascular, very, very, and it was actually very, very painful. The person was saying it's very, very painful. And interestingly, they were like, "Oh, I think I know what it is." And I was like, "All right, go on then." And they said GCT. So, right, yeah, well done. Google searched it. They diagnosed themselves. But yeah, you can see that there is this lesion sitting right there, and you can see how it must have kind of over time scalloped into the adjacent cortex. It's got increased vascularity, and you can see it doesn't look particularly big, but was causing this person a fair bit of grief, unfortunately. But hopefully they managed to get rid of that by now. Okay, good, well done. So now we are coming on to the last few cases. Let's go to this one. Can't remember what this one is. Portovenous phase. Okay. Okay, good. Let's see. I hope it's sunny wherever you guys are. It is wonderful weather, and apparently it's very sunny in Sweden as well, so which is great. Okay, let's have a look through. Let's scroll all the way through, all the way through, all the way through. I always do all the way through to the very, very end, so I don't. Oh, so is this case 8? So this is case 8. This is case 8. Yeah, case 8. Okay, so let's go from the very, very top again. Do download the images. It'll make things far, far more easy. And if we came up to this slice, hopefully you guys can see that there's a pretty abnormal appearance to one of the solid organs. So gallbladder looks okay. Yeah, liver looks pretty good. This kidney looks okay. It's this kidney that looks very, very abnormal, like very, very lobulated, looks like it's heterogeneous, very, very expanded, a few areas of low density within there. That collecting system looks a bit enlarged as well. And yeah, so then you think, okay, so this looks like it's something to worry about, isn't it? This looks like this could be a renal cell carcinoma of some sort. And then what we can do is just make sure there's no lymph nodes in the area. Lymph nodes are, something that could be in the vicinity. So I don't think we can see any grossly enlarged lymph nodes anywhere. So that's, well, not great for the patient still, but, not that bad, I guess. And then what we'll do is go to the Mr. Bleak and then have a look at this. And here, can you see that's going to be the renal vein? Yeah, someone said it exactly. So that renal vein looks a little bit less opacified compared to the other side, doesn't it? It just looks very, very abnormal. And if we come back to the axial views, so I've become a real big fan of like MIPPing images, especially when it comes to vascular stuff. Zoom, zoom. Can you see there's like a finger-like projection just going along there like that? So like a bit of thrombus that is extending, and there have been occasions where it extended all the way up into the IVC. But yeah, there is some tumor extension from this into the renal vein. And actually, I think it might be going a lot further than that, all the way up to there. But the IVC looks okay, but it does feel like there's a complete lack of opacification, probably going all the way along to that point there. So yeah, that's exactly right. Well done. So that is a renal vein thrombosis. Probably should make sure there's no destructive bone lesions as well. And I don't think they were, from what I remember. Might be wrong. Let's have a look. Good. Any lung-based metastases? Sometimes you get those. A few bands of atelectasis. Can't say I can see any lung mets, and no one's seen any either. Okay, good. So yeah, exactly. So left renal cell carcinoma with renal vein extension as well. Right. I have hopefully saved a good one for the last one. I hope it's a good one. Let's see. Okay, so it looks like we have three lots of images. We've got a non-contrast study, an arterial study, and a portovenous study as well. Okay, so just wait for that to download. What I'll do is make it like 1 by 3, I guess, and then pull that one there, and then pull that one there. Okay, good. GB, yeah, okay, let's have a look. So I'm going to go for the non-contrast study first. So they've clearly done a non-contrast study and they've done an arterial phase study and a portovenous phase study, right? So there must be a clinical question that they had at the time to do this. So sometimes you get non-contrast studies because the patient's not well enough to have contrast. They've got really dodgy kidneys, got bad renal function. Non-contrast study could also be a CTKB if you're worried that they've got a renal stone. But then you do a arterial phase image and you've got a portovenous phase image, and that's when you start to think that they may be looking for some sort of bleeding point. The point is because you've got contrast here, and it's you can see the contrast is very, very white, very, very bright. And so, how do you know what is contrast versus calcification, especially at this level? Can you see? It can be difficult. So, if you've got the pre and post contrast, you can know that, okay, that's calcification. So, if anything's bright on this one, it's going to be calcification because it corresponds to the non contrast study. Then you got your delayed image. So if there is something that's bleeding, then you may be able to see it on the arterial phase. But let's say it's a really slow bleeder, then you may only be able to see it on the delayed phase or the portovenous phase a little bit later. So the way I always do it is first off, just have a look, just go through, make sure I don't slice my career. So go all the way down, have a look through the entire abdomen and pelvis, and make sure there's nothing grossly abnormal that I've seen. Someone has pointed out there are a few gallstones there, which is completely true. A few radiopaque gallstones. Remember, they don't have to be radiopaque. So sometimes someone has gallstones, but you can't see them on CT scan. But the actual gallbladder wall looks very, very thin, and I don't think it looks particularly inflamed. So I'm not worried about that gallbladder at all. On these images, the pancreas looks okay, the kidneys look okay, and the spleen looks okay as well. So I'm not worried. Let's have a look at the arterial images. So arterial weighted. Sorry, I don't know why I keep saying that. Arterial images. Okay, so lungs look a bit dodgy, don't they? Here, let's have a look. So the lungs look like they've got a lot of stuff going on. Very kind of fluidy, interlobular septal thickening, probably some bronchiectasis as well. But then let's come back to the actual thing at hand. There's a bit of stuff there. Is that a bleeding point? I hope not. Okay, so you see what I mean? How do I know if that's blood or not blood? So that's contrast. Could that be a bleeding point? But actually, if you go to the non-contrast study, you can see that was there already. So probably ingested material rather than the bleed, from what we can see, because it was there already. And then you kind of come down, trying to have a look. Because pancreas looks okay, kidneys look okay. We're gonna have to do the long haul. We're gonna have to go from bowel. We're gonna have to go and follow the bowel. Okay, so this is where we are. We're at the region of the rectum. Let's scroll, let's scroll, let's scroll. Let's scroll. Okay, so it does look a bit thickened, maybe, but not really at the same time. Doesn't look like it's particularly obstructed. Bowel goes this way, going along this way, going along this way. See, this is where I find a bit. Okay, looks like it's curled back on itself, isn't it? So it's curled back this way. Yeah, it's curled back that way. Then it's gone this way, hasn't it? That way, and then upwards. So we're coming up to the descending colon. Descending colon. Okay, descending colon. Coming up to the splenic flexure. Okay. Doesn't look like something bright there, doesn't it? Can you see that? Let's carry on. Just have a look at the rest of the bowel just in case. We'll come back to the non-contrast study because maybe it's just ingested material again. So transverse colon. I think that's a transverse colon. We're still going cross, looping quite far down. Hopefully I don't end up back at the sigmoid. Okay, no, yeah, we're good. Going cross, going cross, going cross. Okay, yeah. We're at the hepatic flexure. And then we're coming up to the cecal pus, all kind of curling around on itself. You've got what that looks like. Is that the appendix somewhere? Can't be 100%. You got that. Okay, so terminal. Okay, so what we did see as we were scrolling through the bowel was an area of high density just over here. And it almost looks like a linear, doesn't it? So now we've got to try and find the similar area located in the non-contrast study. So non-contrast study, I think we're probably around here, isn't it? And that doesn't look like it's got anything going on there. Let's zoom in. Doesn't look like there's any sort of high density material anywhere. Doesn't look like there's any ingested material. But that Let's zoom in a bit. Looks abnormal, doesn't it? Kind of linear almost, and it's all sitting on top there. Okay, let's go to the delayed image and see what that focal area looks like. And it still looks very, very bright, doesn't it? So let's have a look at all three. Zoom in and then pull that across, pull that way, and yeah, zoom in a bit, and then zoom in a bit. So now you can see, isn't it? There is a definite difference, right? So you've got it does look like there is a focal bleeding point here. So you've got a bleeding point there. There's nothing there. You've got contrast here, and you've got contrast that's sitting within this region over here. And so therefore, this would be, I mean, this is something you need to tell them about because actually this patient came in with PR bleeding. They're looking for a focal bleeding point, and this is what they saw. And so they probably need to go in there and make sure that they either like clot this up basically or put yeah, go and deal with it. Now the next thing I always do is just make sure they haven't lost too much blood and have a look at the IVC, just make sure it's not too flattened, make sure there's no intra-abdominal hematoma or anything like that as well. But this one looks like it's there's focal bleeding point, no ischemia or anything like that. But you can see how nicely demonstrated you have from non-contrast to contrast to delayed image. Right. So we have got to the end of my cases, but I have said before, tag me. So I have been tagged. See here, and I get these like I can see the comments coming in, people tagging, all that kind of stuff. It's really fun actually. And this looks like it's been mentioned here. So let's have a look. So this case, what do we see here? So this looks like so first of all, I'm not a neuroradiologist, so I'm going to take a look more of a kind of more for educational purposes. But what I've already read what they've said, and it's actually fairly interesting. So you've got this sort of MRI scan, and I think if we go across down. Oh yeah, so this is going to be your ADCs and your diffusion weighted imaging and stuff like that. So there doesn't look like there's any. Hang on, maybe there is. Can you see that? There's little bits there, dot and dot. Maybe not. Okay, so we're just going through these scans, just try and make sure that we've orientated ourselves quite nicely, and we can see nothing massive going on at the moment. And what is this one? Is that flare or something? Fluid attenuator, so the fluid is dumped down, maybe. Okay, that looks okay. Okay, fine. So as well as T2 weighted images. You can see the fluid there, the scroll from the very, very top all the way down. There does seem to be something popping up there, doesn't it? Can you see that? Is there? I don't know. Okay, let's have a look through. Oh, and maybe there. All right, let's go through. So they did a contrast enhanced study at some point, didn't they? Scroll through, scroll through, scroll through. Can you see there's a dot there, and a dot there, and a dot there. Scroll through, keep scrolling. Look, there's a bit of this enhancement located within that Sylvian fissure there. See any more anywhere else? Look, another dot there. Can you see that? Little one there. The more, maybe there's some more down here as well. Little dot there, little dot there. What other sequences have we got? So there are a few areas, yeah. So so yeah, people are coming out with what could it be? Oh, so can we see the SWI and flare? Okay, so let's see. That's the flare, isn't it? Is that not? Can't see anything gross. What I'll do, I'll lay them out a bit more. So three. And then someone said they want to see this one, this one. You wonder whether some of these do correspond to some of the areas that we saw. Right. Yeah. So people have come out with loads of things. So metastases, yeah, brains, melanoma, yeah, loads of things that this could be. But it turns out it's tuberculosis. So these are tiny tuberculomas that are scattered throughout the brain. So that's really interesting, isn't it? So yeah, thank you for tagging me on that one. That's a really, really interesting case, and definitely learned something from looking at that one. Now the next one, someone sent. I'm going to go through it, but I can't promise that I know what it is. Let's have a look at this one. So here we go. So thank you for mentioning me again. It's a bit like social media, isn't it? Like being on Facebook back in the day. So what have we got here? So we've got a C-spine. Instead of tagging your friends, you're tagging scans. Zoom in and pan. Okay, so let me know what you guys if you guys see anything. At the moment, it looks like quite a young person, and you can draw around every single one of these vertebrae. They all look nicely aligned. So I always draw these lines going down like this, they're going down like this, going down like this. Anterior, yeah, that looks okay. Vertebra, vertebra, and that one looks a bit odd, doesn't it? And then you've got a bit of this sort of osteophytosis there, maybe a bit of loss of joint space there, potential bit of retrolysis possibly, so where the vertebrae slightly backwards. But the actual everything else looks okay. So this looks like end plate sclerosis and a bit of osteophytosis, some degenerative changes. That area doesn't look quite right, does it? So let's zoom in a bit. So, I mean, I thought they were young because they've got, quite good looking bones, but then that kind of end plate sclerosis and the osteophytosis suggested a bit older than I expected. But there is this bit of what looks like potential scalloping there, doesn't it? But the vertebra above and below looks okay. Soft tissue wise, not much in the way of soft tissue swelling. It looks very, very normal there. So it's hard to know what that is. I mean, it doesn't look particularly aggressive at this point, and I wouldn't be massively worried, but I would probably end up doing, I mean, I don't know, maybe I play it too safe, but I personally would probably end up doing an MRI scan to have a closer look and see what's going on there because maybe they had an old injury, maybe they've, back in the day had a bit of a flexion injury that's resulted in a bit of loss of bone, but I can't see any donor bits of bone anywhere. But it does look like it's kind of got a dent formation there. Doesn't look like it's eaten thing. Doesn't look like there's any soft tissue swelling. Doesn't look like there's any like scalloping of the bone anywhere else. Many missing tooth. So they're much older than I thought. Yeah, you're right. They are. Well, they've got lots of fillings, don't they? Yeah, and a few missing teeth at the back. But yeah, I don't actually have the answer to this one. I'm not entirely sure what's caused that. And I personally would do a MRI scan to have a closer look and see what's going on if that was possible. So whoever did tag that, I would be interested in a follow-up scan if there was one. At the very least, a follow-up X-ray. And if they're asymptomatic, then I guess you can leave it. But I would be interested to know what that would end up becoming. Okay, great. So let's just see if I've been tagged anything else. Otherwise, feel free to tag me as the month goes on. I do my best to try and go through as many as I can. Um, yeah, I do my best to go through them. And I actually like I said, I've said this before, I'm a bit of a radiology nerd. I just like looking at cases. So if you think there's something that I'm interested, I would be interested in, do let me know. Okay, so I think we are going to finish the talk here. So as always, thank you so, so much and so much interaction today. I really, really appreciate it. Always feels like a team effort when we go through these things together. So as always, do good feedback, do give feedback, and do let me know what I'm doing bad, good, whatever. I really don't mind. I want to be the best teacher that I can be. Oh, small plug. If you go to Radiopedia YouTube channel, they've uploaded last year's talk I did for them, and I had a lot of fun pushing the boat with that one. I really tried to make it as different as possible. So if you do have a spare 20 minutes, do watch my video on gym injuries and radiology. I really appreciate it. All right. Till next time, I'll be off and I'll leave you in Natalie's capable hands. All right. Bye.
Thank you so much, Dr. Lasker, for a great session and for joining us today. And thank you, everybody who joined the webinar. Great to have you here. And now I'm going to share in the chat a link to the evaluation form that I mentioned earlier. So here you go. So if you fill out the evaluation form, we will send you a CPD certificate tomorrow, so through email. And of course, as customer success manager, I'm super curious to see your feedback. And just like Dr. Imran Lasker said, tag him on Collective Minds if you want him to have a look at your case. And I hope you all enjoyed the session today, and we really look forward to seeing you in the next session, which is end of July. So thank you all, take care, and see you soon again. Bye.